We are going to figure this out together. So anyway, I'm super excited you're here with us, Guillermo, because I have got a mile-long list of questions. I could probably have you here for 3 hours, but we will try to keep it to an hour or so. But I've got tons of questions in the community. So most of you guys know that we've been doing Facebook Lives with different doctors and practitioners ever since we wrapped up the Fix Your Female Hormones, which is super exciting. And there's tons of questions that happen in the group all the time. And one of the things I'm really committed to is making sure that that we've got resources to support us as we're navigating this terrain and trying to figure things out. Guillermo, for your benefit, I'll just say that what's happening in the group right now with the women is that they're becoming really proactive about advocating for themselves. I shouldn't say becoming. I'm sure a lot of these women have been trying forever, but they're trying new things, you know, and they're getting some clarity around what optimal lab ranges look like. And they want to get their labs run. They want to really see what's going on in their bodies instead of just feeling the symptoms and having doctors tell them that they're fine and that everything in their labs is normal. You know, they're really trying to be more proactive. So as a result of that, they're getting these experiences as they get out there, and it just brings up a flood of questions. So I am just going to like rapid fire the questions to you. I feel like Alex Trebek today. Alexa, I'm Alexa Trebek, and we have questions galore, and every single one of these is probably worth at least $500. Okay, so let's jump in. Why don't you start off by just in like 30 seconds telling everyone a little bit about your background so they get an idea of the space that you come from, and then we'll start launching questions to you.
So, you know, I've been in this health space, you know, since around 2008. I started listening to, you know, Rob Wolf and Kresser and, you know, all those guys. And I was working at a level 1 trauma center for kids. And I was like, you know, I'm doing really cool things here, but am I really fixing the underlying cause of the problem? You know, we can be a lot like mechanics, you know, when it comes to the body. And I wasn't satisfied with here's your pill, move on, here's your pill, because we can fix traumatic situations. We can get someone out of a very dangerous situation in the emergency department. And then when we discharge them, you know, it's always like, okay, now you need to go back home and eat a healthy diet, you know? And
right.
What does that mean? You know, you've been eating, you know, can I curse?
A little, sure.
Okay.
I do.
You know, be eating a shitty diet for 50 years. And all of a sudden, you know, this dude, you know, with a white coat walks in and says, eat a healthy diet. And all of a sudden, boom, mind blown. And you're going to start doing that stuff. So I was an EMT in the emergency department, and I was like, okay, I want to be a doctor, but I want to be a different type of doctor. And I want to be a doctor that is going to be able to sit down with, you know, my patients and have a real conversation, you know, and when I say, you know what, maybe you should avoid wheat. Maybe you should try the paleo diet. You know, I don't want patients to be like, what's that? I want patients that are going to be like, dude, I've been doing that for the past 5 years. Come at me. You know, I want a little bit more savvier population, because that is the people that need a ton of help. People that are that like in your group, Healing Rosie, and I love the group, super engaged, and are actually taking care of their health, not because someone else told them, not because, you know, because that, you know, health is wealth. So that's the type of people that I want to help. And I want to help with nutrition. I want to help with supplementation when necessary. I want to help with medications when necessary. So naturopathic medicine found me, not the other way around, because this is the way that we used to practice. So I'm an open book, and I can, you know, definitely any questions that you guys have. I know we have a list of questions, and we're going to try to rapid fire them. Let's get as much content for you guys and to help you find a practitioner and find your way to health.
Awesome. All right. So let's start with a question from Christine. She's wondering what your thoughts are on iodine supplementation for hypothyroidism.
Okay, so iodine, you know, just wrote a paper that is going to be published, hopefully, on NDNR for the endocrinology issue. And iodine is like this whole big monster. I'm going to try to be very brief, okay? But if you do Alan Christensen, if you go to Google and do Alan Christensen and then put iodine, you can see a bunch of a lot of research that, yeah, in populations where iodine is deficient, and you start developing a goiter because your thyroid gland starts to grow in order to have more surface area. The thyroid gland, it's basically a factory to concentrate iodine into thyroglobulin to create T4 and eventually T3. So your TSH, the thyroid stimulating hormone, calls upon the thyroid, okay, with the TSH. So if your levels are high, that means you're hypothyroid. But TSH is also a growth factor for your thyroid. So the more TSH, the more it's going to grow. And then that's why you develop a goiter. And that's why reducing iodine, or sorry, reducing your TSH reduces the goiter, because it's like a growth hormone for the thyroid. The problem is that if you have too much iodine, you can burn the thyroid. It's like throwing jet fuel into the thyroid. And you can look into the research in China, in places where there's low iodine, the incidence of autoimmune thyroiditis is lower. There was a great study in Japan where they took kids, okay, and they either supplemented or not supplemented with iodine. The levels of autoimmune thyroiditis on the people that were supplemented with iodine was 36% higher than the people that did not take the iodine. So it's very specific. If you live in a country that doesn't have access to iodine through food, then you should have a little of iodine. That's not the United States. That's not most countries where there is a little bit of iodine in the salt. But what is true is that if you ingest iodine, your chances of exacerbating autoimmune thyroiditis are higher. So for this reason, you should try to limit your iodine to around 100 micrograms a day. The funny thing is that thyroid medication has T3 or T4 or a combination, you know, and thyroid medication, that thyroglobulin, T3 or T4 is actually made with molecules of iodine. In the case of T4, it has 4 molecules of iodine. T3 has 3 molecules of iodine. In fact, my favorite thyroid medication, Natrothyroid, is around 19%, 0.20% iodine. And that right there in 1 grain is around 100 micrograms of iodine. So it already has enough iodine for you to produce good hormonal status. Anything extra is going to increase your chances of autoimmune thyroiditis. In fact, there is a study where the treatment for autoimmune thyroiditis was a low iodine diet. And that in itself reversed the autoimmune thyroiditis. So it sounds counterintuitive. I know there's a lot of information online about the wonders of iodine. Iodine is good in populations where there is not access to iodine. Iodine is bad for autoimmune thyroiditis, which is the prevalent cause of low thyroid hormone in North America and most of the world. One final thing is that, you know, in order for you to just remember, you know, just taking thyroid hormone is giving you iodine. So it's very easy for you to go over those 100 micrograms if you are taking the thyroid hormone plus taking a supplement.
Mm-hmm. In your practice, I'm assuming that based on what you're saying, that you don't recommend people take iodine, that you would put someone on NDT or something similar instead. Okay.
Michelle.
Is she texting you? Michelle, quit distracting us. She texted me too. Yeah. So I was asking, in your practice, I'm assuming that you wouldn't tell people to take iodine. You would put them on NDT or something similar, a nature thyroid or something like that.
Correct. Yeah, because you don't want to exacerbate those, that autoimmune condition. A little bit about autoimmune thyroiditis. The auto antibodies are made within the thyroid. Okay, so anything that kind of like pushes or messes with the thyroid is going to agitate it, and then the immune system is going to notice it, and then you start making thyroid antibodies. For that reason, putting a little bit of fuel in the form of iodine is going to exacerbate autoimmune thyroiditis. So is like trauma, like if you're constantly giving you throat massages, or high levels of TSH outside reference range, because anything above like between 0.5 and 1 is going to be too stimulating, and then your thyroid is going to try to make more thyroid hormone, which alerts the immune system, which increases your antibodies. So anything that makes your thyroid uncomfortable or makes your thyroid work harder will elevate your thyroid antibodies.
Okay, great. This is good information. All right, next question is from Terry. The past 2 weeks, my voice has started cracking and sounding more and more like Marge Simpson's. I have Hashimoto's. Is this why?
So if you go and look at the tables for the different symptoms for Hashimoto's, number one, so there's a lot of symptoms. So tiredness, brain fog, hair loss, changes in voice, hoarseness, decreased tendon reflex. There's a slot of symptoms. There is not one symptom that is 100% specific and 100% sensitive, or gets even close for being like a direct correlation for Hashimoto's or autoimmune hypothyroid. But that also means that no symptom can rule it out. Meaning, like for example, if you say, I have pain in my hand, okay, that could rule in having a broken hand. But if you don't have pain, that can basically rule out a broken hand. There is no symptom that can rule out Hashimoto's. Funny enough, one of the highest specificity and sensitivity is a change in hoarseness of voice. Not hoarse voice, it's a change in hoarseness of voice. And I think that's 29% sensitive, and I think 98% specific. And that's probably one of the highest ones. So yeah, it could very much be due to an increase in goiter or in thyroid size, or damage to the thyroid that can, exacerbate other structures. So, just make sure you get your thyroid levels under control. Make sure you get your TSH. Make sure you get your antibodies checked, and try to decrease that in order to try to reverse that symptom.
Okay, great. Alrighty. Corey said, I feel absolutely crazy the week of my period. My anxiety goes into 110% overdrive. I'm in fight or flight mode most of the day. I have no patience for anything, screaming, crying, wanting to punch a wall in rage. I honestly feel psycho. I just want to feel normal. Any suggestions to deal with these out of control hormones?
Well, so that to me sounds more like a cortisol, kind of a problem. Like maybe you have really high cortisol levels. So anytime you have high estrogen levels, and this is gonna tie into the next a question down the road, your body and your liver produces proteins that bind to estrogen levels, to estrogen hormone, and at the same time you also release thyroid binding globulin. Okay, and that makes your thyroid inactive, your thyroid hormone inactive. So whenever you have a problem of like cortisol dysregulation, I know that, there's a lot of people saying, oh, adrenal fatigue, that's BS, that doesn't exist. But HPA axis dysfunction is a very real thing. And whenever you have anything that is going to change the production of thyroid or change the production of estrogen and testosterone and kind of make that seesaw uneven, then your adrenals are going to try to kick in by increasing cortisol, because you're going to have something revving up the engine. If that goes on the wayside and it's too much and your body stops responding to that cortisol signal, you might rely on epinephrine in order to get that energy. And coming down of that epinephrine, right, is really hard. You guys have seen it on the movies, you know, like sometimes, you know, like you have someone sleeping and all of a sudden they would go, you know, that's basically an epinephrine spike. And that's basically how it feels. So how do we combat this cortisol dysregulation? Well, super easy. Just don't have any stress. Super easily said.
Right.
Super easily
You're
said.
fixed.
Yeah, you're fixed. Definitely, lifestyle is the hardest thing you can do, but it's going to give you, it's going to bring you back more than anything else. There are stressors that we can control, and there are stressors that we cannot control. So traffic, you cannot control that. If you're in school, you cannot control finals. You know, taxes, you cannot control that. Holiday season, you cannot control that. But we can control our sleep schedule. We can control how clean we eat. We can control meditation. All of those things that we can control should be your top priority. Okay. When I was in school, people would say, oh, you know what? I'm so stressed out. It's finals week. I'm going to eat whatever the hell I want. That's the worst decision you can make, because you are adding stress upon stress upon stress.
Right.
Now, there are supplements that you can use in the short term to help you regulate and maybe facilitate that cortisol curve. So you can do, you know, a little bit of phosphatidylserine, or you can do a little bit of B6, or even some adrenal cortex in the morning before 10 a.m. so you don't stay awake the whole night. But that is just a Band-Aid. That is not true cure. If you really want to fix those hormonal spikes, try to lay down all your labs and try to figure out where the spike is occurring. If there is something every month that's happening around that time that is making you even more stressed, and try to mitigate that. This is where you being your own advocate is going to be the most important thing, because no one is going to care as much as you do about your health. And if that paper looks, oh, you know, your levels are right, but they haven't tested your cortisol level around that time. If that paper, you know, your testosterone and your estrogen level look pretty good, but they haven't tested your TSH during that time, that's where you're going to have to be a little bit savvier and investigate what that HPA axis is doing differently during that time of the month, and then you will find some solutions.
And this is where it's really important from my perspective as a patient. One thing that I've learned how to do is really advocate for having complete lab sets drawn. So if I'm working on thyroid and we're trying to optimize thyroid, whenever I go in, I have a whole bunch of labs, including iron labs and all the other data that we would need to correlate to make sense of those main numbers when I'm having labs drawn. So that's a way that we as patients can just advocate. Like, I'll actually say to my doctor, well, we're just going to check, we're putting you on T3. We're just going to check your T3 in 6 weeks. I'm like, actually, how about we check my entire thyroid in 6 weeks? Because if that number is off, we're not going to know what it means. And then we're going to have to go run more labs. And you would think it would just be an obvious thing that the doctor is going to run labs or they'd be able to correlate the data, but they don't. And what ends up happening from a patient's perspective is, instead of getting help in 4 weeks, it takes 4 months, because we keep having to go back and have more labs done and make new appointments, and it's maddening. That's just my little 2 cents. Okay, next question. This is from Michelle. What is a good estrone number, and is it important to track estrone with labs?
Yes, just today I had a case where the estradiol levels were normal, and the estrone were through the roof. I like to keep estrone levels as low as possible. So estrone is produced in the fat tissue, and it really is not very active. This is the bad estrogen, the one that you don't want, the one that is more, that is going to create more testosterone. So estrone's lower, the better, preferably, 30 to 60, 70, most in really, this is like one lab and one supplement that can really be changed in like pharmacological, like a pharmacological response almost, using some DIM. Just like using some ester reset, it's a great combination of a little bit of botanicals, calcium gluconorate, and DIM. And that really has been a big needle mover. It is rare that one of my patients doesn't walk away with at least a 30-day, prescription for, let's do DIM for 30 days. Even guys, I take DIM for 30 days once a year, because like I'm standing in this room right here, and like there's carpet, and there, every once in a while, we have to drink from a plastic bottle, and all of that accumulates. All of those BPAs, all of those endocrine disruptors accumulate, and they are mostly estrogenic. So having like a little cleanse, 30 days with some DIM can be really, really beneficial. I really, really like Estro Reset. There's another product called Estro Block Plus. That's a little bit of a higher dose. It doesn't have like Vitex or the botanicals. And I know most of the people watching are going to be females, but maybe in the stocking stuffer, throw your guy a little bit of
just what he wanted for Christmas.
Yeah, just what he wanted. Better sex, and no.
That's right.
Who doesn't want that?
That's right.
Someone gave me a bottle of DIM for Christmas.
Mm-hmm.
I was so lost.
I'm not going to forget that. So Estro Reset, I'm assuming this is something that we can get online pretty easily.
I think you can get it on my website.
Okay.
And if you can't, like you can get it, not my website, but like you go to alanchristiansen.com. That I really like the product. If not, Estro Block Plus, and that's a little bit higher levels of DIM. But
how do you dose Estro Reset normally with your patients?
2 to 4 daily. And then the Estro Block, I think, is 2. The Estro Block Plus is 2. But that's something that I really like to use, and that lowers those estrogen levels. Now, how do we get into high estrogen levels in the first place? Well, a couple of ways. If you are overdosing on hormones, meaning you're aromatizing too much testosterone into estrogen. If you are applying too much, like a testosterone, like an estrogen cream, like a biased birth control, shout out to Jolene Bryden ND, who's coming out with a book in the future about post birth control syndrome. Been geeking out with her, and you should have her as a Facebook Live. Awesome girl, I can connect you.
Yeah.
So if you have done estrogen therapy for a long time, that can rise, and that's the problem. Like if you're taking HRT, that can raise your levels of estrone and not your estradiol. And people are like, well, the estradiol is the most important. Yeah, it's the most beneficial, but that estrogen dominance can be hidden in that estrone. So it's very important to check both. And you don't have to do it, like as often as a TSH with T3 and T4, but doing it, at least maybe if you're checking your hormones every 3 months, so 4 times a year, maybe if you do estrone twice, and that can
give you an idea of what's happening.
Yeah, and then thirdly, there's two ways of checking estrone LC mass spec or PCR, equally as effective in predicting estrogen dominance. I prefer doing the LC mass spec because the other one takes like 3 or 4 weeks to come back. So estrone LC mass spec would be the way of going about it.
Okay. Next question is from Lucy. I'm in a tailspin. My hematologist says I have iron deficiency because of my periods. Mind you, I haven't had a period in over 9 months. I know it's iron deficiency, but this is the only reason he could come up with as to why my iron is low. 30 years of past periods, he said. Strange, right? My ferritin levels are higher than normal. If there is high iron storage, why are my iron saturation and TIBC so low?
That's a beautiful question. I'm going to answer something really fast for Michelle. Is there a problem with doing DIM when you're on estradiol? DIM doesn't actually affect hormone production. It makes estrogen more water soluble for you to eliminate it. So in a way, the way it works is by allowing your liver to clear that hormone. So it doesn't really affect your ovaries or if you're taking it, just helps your liver make it, that's why I think it's an amazing thing. It comes from broccoli, super safe to use. And no, it does not affect if you're taking estrogen. It just makes you more efficient at detoxification. So for iron, this is an amazing question because we miss this so much in medicine. Okay, so there is something called anemia of chronic disease, and your body is an amazing evolutionary machine that has evolved to protect you from dying. And one of the most important things that you can do for an infection is to give them free rein on iron. If, viruses and bacteria use iron in order to reproduce. It's very important for life, okay? So what ends up happening is that if you start noticing an infection, the body starts hiding away iron to prevent the bacteria from using it. How cool is that? There's an excellent study where people went to, missionaries went to Africa, to malaria-stricken parts of the continent, and they were just testing kids. Do you have low iron? And they started giving those little red pills that make you constipated. And the kids started having fulminant malaria infections. Their body was hiding away the iron to protect the kids from having an overt infection. So there's a couple, it's amazing. So that's why it's not just let's look at your labs. Oh, A equals B, here's your C. No, we need to figure out what's going on. There's a couple of ways you can have, this iron, anemia of chronic disease, it's called. And that could be a viral, a chronic viral infection, a chronic parasitic infection, a chronic bacterial infection, and in some cancers that can happen because your body needs iron in order to make those cells replicate. What sounds to me is that you have some chronic infection that has not been discovered. So go ahead and go get, your specialty tests. Make sure you get a good stool analysis with ova and parasite. Make sure you check, that's where I would start because that's where if I was going to put money into something, I would start with that. I would start with stool analysis. If that doesn't show anything and it's a solid stool analysis, then you can start moving into Lyme or EBV. If you're in the Northeast, more likely. Another thing that could be happening is that your body is confused and doesn't know what it's doing, and you have a condition that can be described as thalassemia, and that could indicate some metal toxicity. So make sure you and of course check a CBC, check a CAM panel, check HCRP, HSCRP, check make sure your blood red blood cells are well formed and you don't have a bleed, or that could indicate maybe an ulcer, maybe something like that. So make sure you check all of those marks first. More than likely you have some sort of parasitic infection or bacterial infection in either in your large intestine or your small intestine. And as soon as you clear that, then the body's going to be like, okay, we're gone. Now we can start releasing some of this excess iron.
Okay, so a couple questions along those lines. First, Lucy's asking if she should be taking iron supplements because her hematologist is insisting that she does. But based on what you're saying, that's not resonating for her. Can you answer that?
Find a second opinion. At some point, and this is so difficult because I don't have those labs in front of me.
Sure.
But being they think that that this is rare, or if you were bleeding, you would see a couple of changes in your MCV. You would see a couple of very marked changes in your hematology, and that's and those are not hard to miss. Those are not functional ranges. Those are not, you see an elevation of your MCV, you see low hematocrit, low, if you start seeing those things, then yeah, you can start looking into maybe an ulcer, maybe something like that.
Mm-hmm.
Heavy period is calling it. What I don't like is that you do have high ferritin, and that's like the differentiating factor. It doesn't, I haven't seen your levels. I don't know what's going on, but unless they were like super, super elevated, then I would start, maybe a genetic condition where you have some level of hemochromatosis. But I don't even know what, supplements they're recommending. I don't, so just make sure you follow this thread and try to work with a functional medicine doctor that is going to be willing to listen and play for your team, not against you.
Mm-hmm. Awesome. Okay. Next question is from Elizabeth. How do you go after Epstein-Barr virus in your practice?
That's a difficult question, because everyone has had Epstein-Barr, by when you're 14, 15, you pretty much you have had Epstein-Barr. We don't usually follow that thread too heavily because even though Hashimoto's thyroiditis has a correlation with being triggered by a previous EBV infection, other viruses can do the same thing, such as hepatitis C, such as HSV1, HSV2. So all of these different virus, CMV is another one, can cause this mimicry where you start creating antibodies to your thyroid. So instead of trying to clear the infection, you're basically never going to be able to completely 1000% clear every single viral infection in your body. We try to normalize TSH levels. We try to help with your immune system by removing endocrine disruptors, by helping with hidden infections. And then thirdly, we optimize your immune system in order for your immune system to take care of the virus. You've been following any of the newer technologies when it comes to cancer. Most of the research is going against immune therapies, because there's no way a cancer drug or a cancer supplement or whatever is going to find every single cell in your body. At some point, we're going to have to let the immune system figure it out. So by improving your immune system, you're going to be able to fight these problems. And we have plenty of patients that are symptom-free and still have an IgG response to EBV. So if you were to test everyone for EBV, you would have high rates of EBV antibodies, but that doesn't really correlate to the symptoms. Now if you if you believe and you want to work with someone that specializes in EBV or Bartonella, and Dr. Evan Hirsch out of Seattle, Washington has a more comprehensive EBV, Bartonella, Lyme disease protocols. He's amazing with that, and I've seen really cool things with like ozone therapy, for kind of going intracellular autohemolytic ozone therapy. So that's another route. But if I have a patient that has autoimmune thyroiditis, that I can't figure out, and I start believing, okay, they have a viral infection, I much rather go with someone that is doing it every day, all day long, than me trying to reconfigure the wheel. I prefer focusing on.
So you would refer to a specialist, is what you're saying?
To an EBV specialist, yeah.
Okay. All right. Kimber said, how do you talk to your primary care doctor about your thyroid test results that are less than optimal levels, that are within Kaiser's accepted range? My symptoms point to hypothyroid, but tests say I'm fine. So basically, she's looking at optimal ranges. Her doctor's probably looking at what we call the disease ranges, right?
Yeah.
And she's saying, how do I have a conversation with my doctor about this?
This is a very difficult, conversation, because it's like we're evidence-based in healthcare in the United States up until it's convenient. Once it's not convenient, then you start going, oh, well, and it's in both sides, once it's not convenient, then you start, well, that's not a double-blind placebo-controlled trial, or that's not a meta-analysis, or that's in vitro. And we start forgetting about the scientific process, and we start forgetting that when there's lack of evidence, you have to kind of like dig deeper and then find the best evidence and present it. There is a fantastic Turkish study, and the difference when they were setting those TSH levels is that they added an ultrasound. That was it. And people with clean thyroids, with not extra vascularization, and with no nodules and no symptoms, had thyroid levels between 0.5 and 1. In the previous studies, they would basically say, do you have a thyroid problem? And they would say, no. They would draw the levels, and that's why we see that 0.45 to 4.5 level, and that's why it's so wide, because they might not have symptoms, but that doesn't mean that there are not cytological or cell changes to the thyroid, which is what we worry about. Other than the hypothyroid and having low thyroid levels, the second most concerning thing is that this autoimmune disorder is attacking your thyroid, and it can create nodules that can progress to cyst and can progress to cancer. And we don't want that. We want to reverse those nodules and keep the structural function of our thyroid. And for this reason, we want to keep those TSH levels between 0.5 and 1. So how do you convince a vegan to eat meat? How do you convince a, and I don't care, I don't want to infringe on anyone, and I just want to make a point of how do you convince a pharmacist to that has a religious exception to give you Plan B? Sure, it is their duty, but at some point you have to start thinking about their license, and maybe if something, let's say you take the thyroid medication because you want to suppress that, and then you get hit by a bus, and then now someone, a good lawyer can make an argument, oh, it was because she was taking too much thyroid, and now his license is gone. So find a doctor that agrees with you. I know it's super hard because now you're going outside of, the Kaiser Permanente, insurance, scenarios or whatever. The one thing we should be investing money in is in our health, and I'm not talking about going to I've heard functional medicine doctors say, oh, before you even come in through the door, you got to do $7,000 worth of testing. No, I'm not talking about that either. I'm talking about a well-balanced physician that is going to use the best evidence to help you. And what the evidence says is that resolution of symptoms, reduction in nodules, and in thyroid cytology best works between 0.5 and 1. Anything below 0.3 predisposes you to bone loss, arrhythmias, and cardiac tissue damage. So we don't want to over suppress. What we want to do is we want to keep those levels between that 0.5 and 1. That's what the evidence says. And when that NDNR article comes out, I'll post it to you guys. I think it's going to be coming out earlier next year. And it's going to be well cited, and it's going to sound like it's going to be so dry and boring, but maybe that will jostle the mind of doctors in the future and see why we should be treating this way.
Yeah, I think you said it really, Guillermo. Like, I've been on this journey for a really long time. Going into your doctor and trying to get him to treat something that he doesn't want to treat is a dead end road. You're wasting time and energy that you cannot get back. I know the mentality. I had it. I want my insurance to cover this. I need this person to request labs for all these reasons. And it's so rarely, I'm trying to not be so it never works, but it doesn't work. I mean, I have tons of friends who've been down this road and colleagues, and you see women in the group that are struggling going to their doctors that don't want to acknowledge. You can't get them to. Trying to educate your doctors on this stuff is it's the wrong direction and not the right use of your energy, especially if you're already broken and stressed out and your body's in a disease state as it is. Be smart about this and find someone to help you that wants to help you, that desires to help you, that is on board with your health goals and wants to help you optimize this stuff. It's very hard to convince a doctor to do something.
Yeah, it's like if a patient came in with normal, cholesterol of 199, and they said to me, you know what, I've been reading a lot of Facebook and I've been reading a lot of blogs, and I think I need a statin. And I would be like, no,
it's never happening.
No. I just really, I just feel like I need some metformin, and then I would be like, no, let's do some other stuff. And, so I would never do it, and I understand that they're not our enemies, our MD friends, we have more in common, and we want the safety of you. Unfortunately, there is a lot of misinformation when it comes to thyroid health. And thyroid hormone is not without risk, and that's why, we have to be very careful with that range. And I have seen plenty of patients that have been overdosed, and talk about hard to, get people to get those thyroid levels lower. Because you're going to feel tired, but once your body starts accepting the new levels, everything starts working because you're not revving that engine super hot. So, let me talk a little bit about that. I want to talk about what I mean by that. So you guys have heard of insulin resistance, okay? Insulin resistance is when you have so much sugar circulating in your blood that your body's like, okay, if we continue burning this sugar, we're going to explode our mitochondria. So I'm going to shut off the insulin, and you become insulin resistant. So now you have sugar circulating in your blood, and then you get diabetes, okay? When you have too high, really high levels of thyroid hormone circulating in your body, That thyroid hormone it goes into the nucleus and it starts creating different proteins for signaling, for growth, for all sorts of things. If your thyroid levels in your blood are too high, where your TSH is too suppressed, your cells go, okay, that's enough. We cannot continue working this nucleus 24/7, and you become a little bit of thyroid resistant. How do you overcome that? Well, you start feeling a little bit tired, your hair starts to fall, maybe your voice changes. So you go to your functional doctor and you go, you know what? I was taking a little bit of thyroid. I felt good. So I started taking more and I felt better. And now I'm starting to feel worse again. So then they up the dose. And again, so you're pushing that, and you're forcing that evolutionary mechanism of protection. And then you bypass it, just like if you were injecting extra insulin until you bypass the insulin resistance. You stop becoming thyroid resistant, and then your body goes, okay, that was a lot. They bypassed, now we need to do it again. Let's stop, let's become even more thyroid resistant. So then you go back to your doctor. And it makes sense that, okay, you used to feel crappy, and now you don't feel so crappy. And what I did was increase that thyroid dose. So let's increase it again. And that's how you end up with people taking 3-4 grains of thyroid, when a physiological thyroid only makes around 112 micrograms of T4. That's it, 112 micrograms of T4. That's what a 72 kilo person would make on a regular functioning body. Think about it in the pancreas. Imagine if the pancreas, and I don't know the exact numbers, is only making, 3 cc's of insulin, or 12, units of insulin a day. And you're like, well, I'm going to inject 60. There is something wrong. There is something wrong going on. Why do you need so much more insulin if your pancreas in a day only produces 12 cc's? And again, those are not the numbers. But what I am sure is that a person that weighs around 150 pounds, 72 kilos, with an intact, perfectly functioning thyroid that does not have Hashimoto's, only makes around 112 micrograms of T4. Now, how come some people end up taking more than 112? Well, different reasons. You could have poor digestion, and you need, 160 or 130 or 135 to have enough to bypass those digestion problems. Well, if you fix your digestion, then you can reduce your dose. Maybe you have, you are sick, and you have lost a lot of weight, and you need a little bit more for ramping up metabolism. Maybe you are going to need a little bit more. Maybe you're having a kid. Whenever you get pregnant, your thyroid levels need to increase in order to make another baby, another person. But all of those can be explained. What cannot be explained is a female that weighs 110 pounds soaking wet taking the equivalent of 6 steroids every day. And that's when you see a lot of this cardiac problems, a lot of this bone problems, a lot of this chronic fatigue syndromes, and it's because of reactive oxygen species from overutilizing cells all over the body. And this is very well documented in the literature, and that's that's one thing that, unless we correct that, unless we start being very serious about talking about this subject, our MD friends are going to take it the opposite way, because it is safer to be hypothyroid. Because what's the problems of being hypothyroid? Well, you're going to feel fatigue. Maybe your hair is going to fall. Maybe you're not going to have a lot of energy. What are the problems of being hyperthyroid for a very long time? Death. So it is safer. They're going to err on the side of cautiousness, and they're going to keep you on the higher levels of TSH, because they don't want you to go into that iatrogenic hyperthyroid state.
So this kind of reminds me of what comes up in the community a lot when we talk about, supporting our thyroid and doing bioidentical hormone replacement and everything else. And at the end of the day, what these options, you know, doing thyroid support, doing bioidentical hormone, these are great ways to give our bodies a little extra support, but they are not the fix.
Yeah.
What we have to do is keep looking deeper, keep looking upstream, as many of our colleagues say, and figure out what's actually happening that's creating this stress state in the body to begin with, that's throwing everything off. So anyway, just to kind of tie a ribbon around what you were saying there. Next question here is from Zarina. What is the best way to shrink multiple nodules on your thyroid? And how do you know if a biopsy is necessary?
So when it comes to biopsies, I want to have your best interest. And I do follow 100% the standard, procedure, the TRATs for biopsies. And I think, if you don't quote me on this, but I think it's 5 centimeters and above needs to be biopsied. What is the most effective way of reducing nodules? Again, so TSH, thyroid stimulating hormone, is the hormone that goes from the pituitary into the thyroid and goes, hey, thyroid, start making more thyroid hormone. It does a couple of things. It stimulates the thyroid into production, and it also enlarges it, okay, to make it, to have a little bit more surface area so it can grab even more iodine and produce more thyroid hormone, okay? So TSH is a growth factor for the thyroid. So what happens when you have something nagging and just eating at the thyroid, in the case of autoimmune thyroiditis, immunoglobulins, irritating it, well, you're going to create a nodule. And if you're irritating and you're growing, it's going to grow that nodule, okay? So the best way to reduce your nodules is to have excellent levels of TSH between 0.5 and 1. Below that, okay, you are upregulating every other cell in the body, not just your thyroid. And that's going to stress your thyroid too, because your immune system is going to be overstimulated. And so you don't want to be too low. There's one case where you want to be at 0, and that's with thyroid cancer. And you want to have it at 0 because the risks of metastatic cancer are greater than the risks of bone loss and cardiac disease. So in those cases, you do want to suppress it a little bit more, but that's only if you were diagnosed with thyroid cancer that was metastatic and they took your thyroid away and you're keeping it at 0. Why? To make sure that if the surgeon by mistake left any traces of thyroid, that little trace of thyroid doesn't grow. And that's why the TSH is a very, very important marker, okay? That sometimes we think, oh, you're just checking TSH. Oh, you're so antiquated. I thought you were, no, TSH is like prime, because it's your internal thermometer that is sensing how much thyroid you need according to your situation. So that's why it's so important to have good levels of TSH.
All right, that's a perfect setup for the next question from Kathy. What does it mean when your TSH is at a good level, 1.65, but your free T3 and T4 are at the low end of the optimal lab range? My hormone doc wants me on a natural thyroid hormone, yet I think that my levels would indicate the issue isn't my thyroid. Could it be pituitary or something else?
So the incidence of pituitary problems is like super rare in the United States. I think that when we try to explain something that doesn't make sense on paper, we're like, oh, it can't be the thyroid, it's going to be the pituitary. The incidence of pituitary problems when it comes to thyroid, super rare. And if you had high prolactin levels, like really high prolactin levels, and decrease in all of your hormones, because remember, your pituitary is not just making thyroid hormone, it's also making cortisol, CHR, and it's making your cortical releasing hormone, and it's making your TSH, and it's making your sex hormones, and everything. If you are low on all of your corticotropins and everything, and you have high prolactin levels, you might have a case. Okay, so you would either have like Cushing's or Addison's, and not just like adrenal insufficiency, but like frank Cushing's or Addison's. Whenever you're making that TSH, it's not like a factory where like they're making these boxes and then your body's like TSH, and just grab the TSH and just put it in a conveyor belt and send it. Whenever you send that signal, you're going through a bunch of tissues and you're stimulating a lot of things, and it makes sense that you make a little bit of TSH, and at the same time you might make a little bit of like corticotropin, because you know that the thyroid is not responding. So you're going to need the HPA axis. You're going to need to activate your adrenals too. Okay, so unless you have this syndrome where like either all of your hormones are low except your prolactin, and prolactin is funny. Prolactin starts going off as the other hormones get suppressed. So it's like it's the inverse. It's like a break. If you have that, then maybe you have a case for maybe a pituitary problem. If you are taking thyroid medication, and let's say you are at a 0.5 to 1 again, okay, and you test without taking that hormone in the morning, so you're tested fasting without taking that thyroid, your free T3 and your free T4 are going to be low. Period. The end. Why? Because whenever you're suppressing your TSH, that gland, your thyroid, kind of goes to bed. It becomes less active. So just like when you inject testosterone and your testicles kind of stop producing testosterone, same thing. Anytime you take a hormone, the gland that makes that hormone kind of stops making that hormone. And that's a good thing, because if you stop making it, that means that it's less attention, hey guys, to the immune system. And that's why it reverses, nodules. Mm-hmm. So, and you can do this trick, you can totally do this. You can take, you take your, next time you have your thyroid labs drawn, don't take the thyroid hormone, and your T3 and T4 are going to be low. If you take your thyroid hormone and then you get your hormone levels, your T3 and T4 are going to be high. Because unless you're not taking thyroid hormone, your thyroid levels are mostly going to come from that pill. So that's, now, why do we ask people not to take the thyroid hormone when if they get their labs? Well, two reasons specifically: to have continuity in the way that we've been testing, and then second, if there is healing of the thyroid, then we can start seeing more efficiency out of the thyroid, and then we can see how you're reacting, and maybe we need to reduce your thyroid medication. So that's why we measure it. But I never make decisions on should I increase on someone that is already taking thyroid hormone with if they are, if the free T3 and free T4 are low. I make decisions on the TSH. That's the most important part. And I'm going, in that NDNR paper that I'm writing, I'm going to disclose why. Now, if you are not taking thyroid hormone, and you're like at 1.6, okay, and your T3 and T4 levels are low, that might indicate that there is an attack on your thyroid. You're just not frankly in hypothyroidism according to those numbers. Does that make sense? So that's where it's very important to test for thyroid antibodies and get an ultrasound, because if there's any cytological changes, even if you're at 1.6, to prevent further damage to your thyroid, I would start dosing a very small dose of thyroid to try to get that TSH between that 0.5 and 1. So, very different scenarios. You are taking a thyroid medication, T3, T4 are low. That could mean that you're healing your thyroid. You are not taking thyroid medication. That means that you are still compensating until you break. So don't wait until you get chronic fatigue, your hair is falling and your voice is changing to start acting. Start, eliminating the most inflammatory foods, start, investigating, make sure you don't have any nodules, make sure you don't have thyroid antibodies. And if you have any of those things, it would be a good idea to start a low dose of thyroid to help you with the healing before it gets worse.
So I just want to reflect back to you to make sure I understood. So basically you're saying 1.65 is high for TSH. Mm-hmm. And that's saying because her free T3 and T4 are a little bit low, the TSH is actually trying to get her body to produce more thyroid. It's not. So she would benefit from a little bit of extra support, extra thyroid support to bring that TSH number down.
Yeah, and that's if she's not already taking thyroid medication.
Sure, I think that she's not because she's resisting. Okay. She said my doc wants me on natural thyroid hormone, but she's not wanting to go on.
Have an ultrasound. Have an ultrasound. Make sure you check antibodies. Okay, and if you have any level of antibodies, that means that your immune system has recognized your thyroid as an intruder, and those antibodies are going to continue trending up. Mm-hmm. That's what that means.
Okay.
And then that ultrasound, make sure you don't have any changes. So it should be homogeneous cytology with no increased blood flow. If you have a heterogeneous with increased blood flow, with endothelial growth, with a little bit of inflammation through goiter or any nodules, do yourself a favor, start on that little thyroid dose. That pill is going to save you a big headache in the future.
Okay. Question from Michelle. What can be the effects of too much selenium on the thyroid?
So on the thyroid, selenium is like super necessary for the deiodination of T4 to T3. The selenosis, it's a disease where you take too much selenium, and I would be more concerned about that than its effects on the thyroid. Having a little bit of selenium every day is a good idea. I think like 2 Brazil nuts a day is it is enough for you to have good selenium status. But I wouldn't worry about the effects of selenium on the thyroid. I would worry more about the selenium toxicity overall, which is really easy to acquire. So just again, eat real food. You said it, Misty. Taking an extra supplement might be helpful, might be a band-aid, not necessarily cure. And the best way to make sure we're getting good status is just to get it from food. Just get your selenium. Chronometer, great app. Input everything for a couple of weeks and see what your nutrient status is averages, and then see what nutrients you need. But don't freak out too much about selenium. Having a little bit as a supplement, maybe 3 times a week or 2 times a week, just to cover your bases is enough. Don't go over supplementing over super physiological doses.
What is your recommended dose for selenium?
It's 200. I can't remember. Give me a second. I'll tell you in a second.
Okay. 200 sounds really familiar, by the way. I think that's recommended often.
Yeah, and then I've been reading a couple of some information on selenium methionine, I think, and that's a little bit better dose of a little bit better form of selenium than the selenocysteine, but or maybe I have them backwards. Yeah, 200 micrograms.
Mm-hmm.
Yeah, and you know, selenocysteine, you know, it's really hard to get. I think only one company is making it, uh, um, but it's a little bit more absorbable. Not a big deal. Just get, you know, 200 micrograms, and you should be fine. Not something that you have to do over the top.
Yeah. We are pretty much at the hour mark here. Do you have time for one more, or should we go ahead and wrap?
Let's do one more.
Okay. This is from Heidi. I'm struggling to get my thyroid levels where they should be. I have Hashis. I'm taking 97.5 milligrams of Nature-Throid and 25 milligrams of liothyronine. I think I said that right. 4.5 milligrams of LDN, and I have been doing AIP for years. My free T3 is slightly low, and free T4 is very low. My reverse T3 is too high. I've brought up my ferritin and iron saturation, which had been low, but my reverse T3 is still high. What causes the free T3 and free T4 to go in opposite directions, and how do you get things optimal again, especially reducing reverse T3?
Okay. So, and did we get TSH levels?
She said her, nope, she didn't say anything about TSH.
Yeah, so you see, you know, and that's the thing, you know, again, so much misinformation because we think, oh, reverse T3 deactivates T3, and if it keeps going up, it's a bad thing. Okay, so the body is way smarter than us and way smarter than the test that we try to come up with to explain situations. Okay. Evolutionarily speaking, there is a reason our body makes reverse T3, and it makes reverse T3 at the highest levels when you are in the ICU. That's where reverse T3 was discovered, and it's in reverse T3 is measured in the ICU because your body's trying to slow you down in order for you to just heal, you know? So that's when reverse T3 is very, very important in the ICU, what we call horizontal disease, whenever you're laying down flat in the bed, okay? What is reverse T3 evolutionarily made for? Is it a mistake that our body, you know, why is our body all of a sudden deciding to, you know, inactivate this very important hormone that affects every single cell in your body? Well, reverse T3 is a bailout mechanism. If you want to lower your reverse T3, you know what the best way of doing it? Stop taking that liothyronine. Stop taking that T3. And I assure you that reverse T3 is going to slow down because your body is sensing that you have too much T3. And what it's doing, it's trying to take it out. And you can see this very readily in Graves' disease, which is the opposite of Hashimoto's. The first thing that happens in Graves, your T3 and T4 levels are good. Your reverse T3 is good, and your TSH begins to drop. So let's say you were at a 1 and you start going to 0.3, 0.2, because the body is noticing that you're making too much thyroid, and you start pooping more, you start, you know, excreting some from the saliva, and you start peeing more thyroid because you're trying to bail it out. The second stage of hyperthyroid, your TSH becomes really suppressed and your reverse T3 starts to climb. Okay, so then now you have like a less than 0.0001 with a reverse T3 slightly climbing little by little. Okay, you're still pooping some, you're still peeing some. Now the reverse T3 is bailing out that excess T3, and that T3 and that T4 maintain that normal level. Okay, the last stage is the TSH is completely suppressed, reverse T3 continues to go up, and now your body can't bail out any more of that free hormone, and your T3 and T4 start going up. That's in hyperthyroidism. So what's happening, I wouldn't be surprised if your TSH is very suppressed, okay? That 97.5 is, you know, it's a grain and a half of, so 150 micrograms of thyroid. Remember, 150-pound person only makes around 112 grams of micrograms of T4. You're taking a little bit more than 100 because Nature has T4 and T3. Plus, you're taking extra T3. So you can see how you're just taking a bunch of jet fuel. I'm not sure what her weight is. I don't know what her situation is, but your body is just trying to bail it out. And then because you're taking exogenous thyroid, your thyroid is chilling. It's not having to make any thyroid. So of course your T4 and T3 levels are going to be low if you haven't taken the medication when you go get those lab tests. Do an experiment. Next time you go get your TSH and your T3 and T4 and your reverse T3, take it before you go into the lab. And you will see that your T3 and T4 are going to be high. Your reverse T3 is going to continue to be high and your TSH is going to be suppressed. So what do? I would start backing down on that T3, okay? Try to get, that hormone level at the right level. Make sure you don't have any problem absorbing the Nature. Make sure you have solid digestion. Make sure you're taking it an hour away from food with just water. Coffee can bind to the T4 to the thyroid hormone for up to 4 hours. And this is something that I just learned recently. So try to take it away from coffee, at least an hour, and just make sure all those ducks are in a row before you start increasing that thyroid. Because the linear thinking of how to get over this would be to add more T3. Your body's converting that T3 to reverse T3. Let's add more T3. Eventually, you're going to bypass that mechanism. Eventually, your T3 levels are going to be skyrocketed. That TSH is going to be suppressed, and your hair is going to be falling out, and you're going to have heart palpitations, and you're going to have a little bit of bone loss, and then you're going to become thyroid resistant, and then that level of thyroid is not going to work, and then you're going to have to increase it, and this vicious cycle that unfortunately I see a lot.
Mm-hmm. Yeah. All right. This has been awesome. We got to like half the questions.
I know.
I could keep you here for like another hour, 2 hours getting through everything, but this is fantastic. These are a lot of the things that have been coming up in the group a lot lately. So I hope this is clarifying. This is a great resource too that we can point others to that have questions about these issues so that they can educate themselves as well. So I appreciate you squeezing us in at the end of the day. Thank you so much, Guillermo.
No problem. And yeah, so check out my podcast with the Wellness Mom. I just had, she just interviewed me,
Yeah, I heard about that. Why don't you tell people where they can find you online and tell us about that interview?
Yeah, so it's really cool. I've met a bunch of great people, through this community. You, Michelle, Keith, Rob, like all these awesome people, and through mutual friends and my mentor, Dr. Al Christensen. I was at Mindshare. You were there, and Dr. Christensen introduced me to Katie, and she was like, "Yeah, let's have an interview." And I was like, "Wow, man, this is so awesome." Because she has a huge following.
She has a huge following,
and to give me like a little bit of a stage, that's amazing. You might not agree 100% with everything I have to say. There's a lot of difference of opinions, and I think this is what this forum that you're creating is exposing, and it's giving everyone hope. You might not agree with like the scientific model, you might not agree with something else, or but you can find a practitioner that's going to be working for you, and that's going to be so much more beneficial than going to someone that just dictates and prescribes.
Totally.
Find your healer. You are your own healer. Find your compass and really go with someone that resonates with you, and that's going to be way more healing than anything else, than having someone tell you from the pedestal down, this is what you're doing wrong. This is what you need to be doing.
Yeah.
You can follow me on any of my on social media, 3030 strong. That's my handle. 3030health.com is my my website. And just so happy to be helping as many people as possible. And thanks for what you're doing, Misty, because like this group rocks.
Thank you. Yeah, I'm totally excited that we get to hold this space and support women and getting answers, especially when it's so hard to get them from our primary care doctors. So thank you for being part of it and for your participation in our group. I'm grateful. I know the women in our group are really grateful too, and I'm sure we'll be seeing you again soon.
Totally. Let me connect you with Jolene, and she has that book coming out, super amazing. And I think a lot of women would benefit from her message.
Awesome. All righty. Well, thanks everyone for joining us. Have an awesome evening.
I love doing this live.
Yes, we'll do it again for sure.
Awesome. I'll talk to you soon.
See you later.
Bye.